I am the spring wind. In the words of the Persian epic poet Ferdowsi, all over Iran is my abode. From the majestic snow-capped Damavand peak to the scorching desert in the heart of Iran. And from the lush woods of the Caspian coast to the azure blue waters of the Persian Gulf. At dawn, when the sun starts its magnificent symphony, I start my journey to the Caspian Greenbelt. I'm in Kashan. I make my way through fresh and sprawling roses and spread their sweet fragrance everywhere. Open the window and let the cheerful, invigorating spring come in. I have traveled all over Iran for years, been more and more bewildered each day by its charms and attractions. Words of the mystic poet Atta of Neshabur. The more you traverse this territory, deeper bewilderment will be. Oh, a biting wind is heading towards me. The last winter cold spell. I get to wrestle with it. With the cold spell defeated, rain clouds shed tears of joy. And the proud plane trees reach their hands up to the sky in prayer. In the words of Rumi, if there is no rain, how shall any tree raise its head in the air? How shall a plane tree open its hands in prayer?
Hello, Professor Slutwijk. Do you have my voice?
You hear my voice as well?
Yes. Great.
Okay.
How are you?
Well, fine, thank you. We had just a discussion because I was wondering about the program.
Yes.
You sent me just a changed schedule a few minutes ago.
Just a title, Professor. Just a title of... Yes.
But does it mean that the case-based discussion is dropped?
No, Dr. Mahdavi included case-based discussion in the first part of her presentation.
Okay, so we will start with the case discussion.
Yes, and a review of histology of salivary glands tumor.
Yes, but I have, you can see you sent me the initial schedule for salivary gland tumors first.
Yes.
And then case-based discussion panel, next hour, and then Professor El Nagar with salivary gland tumors. So
yes. Mm-hmm.
And now I'm a little bit confused because yes. I see now two other titles. I see a title, part one is review and case presentation. So that means that the case-based discussion will be the first item.
Yes, sorry for this change, Professor. In fact, Dr. Mahdavi will have two presentations. At the first part, she will have a review of histological and immunohistochemical profile.
Yes.
Of salivary gland and case presentation.
Yes.
At the second part, Dr. Mahdavi will have a presentation on salivary gland tumors with clear cell changes.
Okay, that's clear. But that means, and we will have, the presentation will be 45 minutes, and thereafter we will have some time for discussion.
Yes,
okay?
Great, exactly. Yes,
so
exactly.
that means that I will ask Dr. Mahdavi to stop after 45 minutes.
Yes,
and then there will be some time for interaction with the audience.
Yes, exactly. Okay? And I will. Yes, exactly. And I will be grateful if we will have 5 to 6 minutes between two presentations of Dr. Mahdavi, and we will have a short video to have a short rest and for the audience and also the lecturer.
Okay, that's up to you. I will say now we are finished and we will come back and then you can say when you would like the audience to be back.
Thank you very much, Professor. Sure. It's a great honor for us to have you as moderator in this panel. Thank you very much.
that remains to be seen. You have to wait.
Thank you. And it seems that we have 10 minutes to begin the panel, and we will be back in 10 minutes. Thank you very much.
Yep.
Thank you. Okay, hello everyone. Welcome to the virtual head and neck pathology course by Tehran University of Medical Sciences. I would like to welcome you all to the second day of the course focusing on salivary gland lesions, and I would like you have enjoyed first day yesterday on odontogenic lesions. At the beginning, I would like to express my sincere appreciation to Professor Dr. Peter Slutweg. He kindly accepted our invitation to moderate this panel today. Professor Slutweg is no need to introduce him, but you know, he's retired professor of pathology, Radboud University, Nijmegen Medical Center, the Netherlands. Professor Slutweg, thank you very much for accepting my invitation, and the platform is yours.
Yes, thank you, Dipujan, for inviting me the second time that we have to share a task now in the last months. And of course, it will be my pleasure to share this afternoon, for you evening event on salivary gland tumors. We have 3 hours ahead, and I see that we already have almost 200 participants. So your program looks very attractive, and I hope that it will come out as intended. And now, of course, it's my great pleasure to introduce the first speaker for this salivary gland session, Dr. Nazanin Madavi from Tehran, from the Shahid Vesti University. I hope I am pronouncing it in the correct way. Dr. Madavi has already a nice track record of efforts and performances in the head and neck pathology, orophathology area by lecturing and publishing about various aspects of the orophathology and neck pathology. So I'm sure that we will be very happy that she shares her experience with ours, and she will give 2 talks this afternoon, the evening for you. And the first one is about a kind of review. I have to check my files, a review of histological and histochemical profile of salivary glands and case presentation. And I will be very happy to hear you talk about this interesting and complicated area. And so, indeed, now the floor is for you. Please go ahead.
Thank you very much, Professor Slutweg, for your nice introduction, and good evening from Tehran. Before starting my presentation, I would like to thank you, Professor Slutweg and Professor Al-Najjar, for accepting our invitation for this short course. It is my pleasure to have lecture in the same panel with you and Professor Al-Najjar. I cannot change my slides. Okay, this presentation is divided into 2 parts. In first part, I'm gonna present a brief review on histological characteristics and immunohistochemical profile of salivary gland tumors, and then I'm gonna present 3 cases. As you know, saliva is secreted by 3 pairs of major salivary glands, including parotid, submandibular, and sublingual glands. There are also minor salivary glands, actually 500 to 1,000 lobular aggregations of minor salivary glands scattered through the oral mucosa. You can find them in buccal mucosa, subpalate, hard palate, except for the anterior region, floor of the mouth, lingual, area and almost everywhere except the gingiva and anterior part of the palate. A fundamental structure of salivary gland tissue includes acinar ductal units. You know, acini are the secretory units, and the acinus empties into a duct. The ductal structure in major salivary gland include intercalated, striated, and excretory ducts. The acini can be serous, composed of serous cells, mucous cells, or a mixture of both. In this case, you have a mucous acini with a serous cell lying in the back of the mucous acini. Some people call it demi-lume or crescent. Regarding the histological characteristics, I can tell you that we have different we have acini cells and ductal cells. The intercalated ducts that connects directly to the acini and somehow connects the striated ducts to the mucous or serous acini is very small and short, and it's difficult to see in routine histological sections. It is composed of cuboidal cells. The striated ducts are composed of columnar cells with some basal projections. And regarding the excretory ducts, you may see cuboidal, columnar, or pseudocolumnar striated epithelium, or even squamous epithelium. We have also some myoepithelial cells that are surrounding acini and intercalated ducts, as you can see, as is shown by the red arrow. So if you want to simplify this structure, you can see that in salivary gland, we have some luminal cells which are directly lining the lumens of acini and ducts. So these are acini and ductal cells. And there are some abluminal cells that supporting these luminal cells. These are myoepithelial cells in acinar and intercalated duct area, and basal cells in striated and excretory duct area. So I took this picture from Diagnostic Histopathology of Fletcher's textbook. This is one of my favorites because it somehow shows you the immunohistochemical profile of all the cells involved in all the cells in the salivary gland structure. So here you can, the reason I'm going to tell you this is that, sometimes you're facing salivary gland tissue and it's difficult to perform the diagnosis based on the pure H&E slides. You need to know the immunohistochemical profile of each cell type. Knowing the cell type can help you to differentiate, to reach the diagnosis. One of the most important cells that can help you for the diagnosis is myoepithelial cells. If you rule out or rule in the presence of myoepithelial cells in some tumor, you have rule out or in group of tumors, so you can separate them and think about the other group. Regarding the luminal cells, which are acinar and ductal cells, most of them are positive for pancytocratin, EMA, and CEA, negative for vimentin, P63, and myeloid markers. Both myoepithelial cells and so now I'm talking about the abluminal cells. Both myoepithelial cells and basal cells are positive for pancytocratin, EMA, CEA, vimentin, and P63. So P63 is positive in both basal and myoepithelial cells. But other markers that we know as myoepithelial markers, including S100, GFAP, and actin, calponi, they're positive in myoepithelial cells and negative in basal cells. section of a parotoid gland. The reason I'm going to show you this picture is I want to focus on the lobular architecture of the gland. This lobular architecture is seen in both minor and major glands and is an important feature of the tumor. Sometimes when you want to differentiate between a tumoral lesion and a non-tumoral process, preservation of the lobular architecture can help you very much. So preservation of a lobular architecture sees you that the process is a non-tumoral process. And as mentioned, parotid gland is almost entirely composed of serous acini, and of course ducts, but the ducts are almost entire serous type. Submandibular gland is mostly a serous type gland, but of course occasional mucous cells could be seen in this gland. The proportion of the mucous cells changes in case to case, but generally we can say that the gland is almost composed of serous gland with little mucous cells. Regarding the sublingual gland, most of the gland is composed of mucous acini. The predominant acini type is mucous cells. However, few serous cells, usually in the form of demilum, could be seen. Minor salivary gland structures, which are scattered through the oral mucosa and also arranged in lobulated fashion, usually are in close contact with the superficial oral epithelium. You know, most of the minor glands are seromucous type, but also you have some serous-only glands at the posterior area of circumvallate papilla and mucous-only gland in the called non-gland in the anterior ventral tongue. So after this brief review of histological and immunohistochemical profile of salivary gland tissue, I will present you some cases. Professor Slutweg, I'm going to start presenting these 3 cases anytime. If you think you need to add some comments, please just stop me. So the first case, you can consider this case as a warm-up. The first case is a 67-year-old lady. She had a soft nodule on the lower labial mucosa for 1 year. The lesion was excised, and this is the histological view of the lesion. Here you can see the overlying oral epithelium. And then there's a cystic space. And then you can see an epithelium is lining the cystic area. And also you can see that the epithelium is folded toward the lumen in one part. Inside the lumen, there's also something that looks mostly like exudate, but we will have a closer look. This is closer look of the lesion. You can see that the lesion is lined by epithelium. This is a more closer look, high power view of the lesion. So in this picture, you can see that the epithelium is composed of cuboidal to columnar cells with occasional mucous cells. Also, you can see the overlying oral epithelium. More closer look, you can see that some cells seems to be ciliated. Here you can see that there are also some flattened cells, cuboidal cells, and some mucous cells. So what do you think the diagnosis is? Please type it in the chat box, 1 for mucous cell and 2 for mucous retention cyst or salivary duct cyst. What do you think? Just type the number in the chat box, please. So I can see many too. Yes, most. So we have many experienced pathologists here. Yes, the answer is mucus retention cyst. So it is a lesion resulting from obstruction of the duct and the accumulation of the saliva. So some authors say mucus retention cyst and salivary duct cyst, they consider both as the same lesion, but some separate these two lesions, like Professor Neville in his textbook. So they believe that mucus retention cyst is, of course, it is a true lesion, true cystic lesion, because it is lined by epithelium, which is the ductal epithelium, and develops secondary to the ductal obstruction. It is rather a cystic dilation, and it's not a true developmental cyst. And the other hand, we believe that salivary duct cyst is a developmental cyst results from the ductal epithelium. So it has nothing to do with the obstruction and accumulation of the mucus inside the duct. This is, so since most of you mentioned the correct answer, most of you choose the correct answer. So I'm gonna just have a quick review of mucus cell, which is results from the injury of the ductal epithelium, and the mucin spills out to the surrounding soft tissue. And after this, we have some inflammatory infiltrates and granulation tissue formation. It is not a true cyst, but mucus retention cyst or salivary duct cyst are true cysts lined by epithelium. So maybe we can go to the next case.
Maybe I would like to interrupt because in one of your first slides, I noted also some kind of material within the cyst wall, and you didn't talk about that background here. This material, what you see here in the center of the cyst, you didn't show any magnification of that. Can you comment on that? Because it just looks me not quite quite debris. I think it's vital material.
The material inside the lumen looks kind of mucus intermixed with mixed inflammatory cells infiltration. If I have yes, this is a closer view of this. There was a mucus background, and there were lots of mixed inflammatory cells infiltration in it.
Yeah, so you consider this to be exfoliated cells with inflammation and debris, and not part of the vital lesion.
Yes.
Okay, that's fine. Because at first glance, when seeing so much cellular material in the center of the cyst, I would also consider to be a kind of an intraductal papilloma.
Yes.
But when you don't see any connection, when you do not see any connection of this material, this intraluminal material with the cyst wall, then you can ignore that. So thank you, and please go ahead with your next case.
Yes, Professor, thank you very much. So the next case is a 39-year-old male. He had a slightly elevated red lesion in his heart palate. The lesion was 3 centimeters. He said that he had it for 2 weeks. The patient, as far as I remember, was addicted to opium for 15 years. And his chief complaint was pain and the presence of the lesion in his, an ulcerated lesion in his palate. The differential diagnosis of the clinician was squamous cell carcinoma. I found this case in our file. I didn't find the radiographic picture of the patient, but there was the radiographic report saying that the lesion is a mucosal lesion with no evidence of bone involvement. So this picture does not belong to my case. I found it in the internet, but it can help you to imagine how the case would look like. It was a slightly elevated lesion with an ulceration. The ulceration looks to be necrotic in some part, and the patient had some degree of pain. This is the incisional biopsy performed. You can see in this picture the overlying whorl mucosa and some squamous islands that some of them are connected to the surface epithelium. And beneath the epithelium is the salivary gland structures, regional salivary gland structure. You can see the dilations of the ducts in this magnification and also the presence of inflammation. This is a more closer view of the lesion. Here you can see some islands of the epithelium of squamous cell. And in this area, if you want me to explain for you what I saw, this is a lobule of salivary gland. You can see there's some acini and ducts. The duct seems to be dilated, and there is also change in the epithelial layer of the ducts. There are some metaplastic changes. I think I have more closer. Yes, I have more closer view of this. You can see the acini and some of them seems to be necrotic. You can see this in the background of inflammation. You can see the changes in acini as well as the ducts. So if I'm too fast, just tell me, I will slow down. This is another view of the lesion. So what is your diagnosis? 1, squamous cell carcinoma. 2, necrotizing myelometaplasia. 3, subacute necrotizing cellulitis, and 4 for mucosal.
Well, indeed, when looking at the chat, I think that you have selected quite typical and very evident case of option 2.
Yes, the case might look easy, or the pathologists here are so expert. Yes, the diagnosis is necrotizing myelometaplasia, which is the lesion resulting from ischemia. So it has different factors that all of them can cause ischemia. There are some like recent surgery, traumatic injury, local anesthesia in that region, ill-fitting denture, or upper respiratory infection. These all can cause this lesion. Regarding the location, one of the most common location of the case is heart palate, as in our case. It causes tenderness and swelling, and then there's an necrotic ulcer in the ulcer that it's accompanied by the reduction in the pain. So its most important differential diagnosis is squamous cell carcinoma and mucoepidermoid carcinoma. If you want to differentiate it from these tumoral lesions, these malignant lesions, one of the most important criteria is the presence of lobular architecture, which you can see here. This is an important feature that can help you in different parts to differentiate between a tumor and a non-tumoral process. Also, you can see the acini have necrosis, and the overlying oral epithelium shows pseudoepitheliomatous hyperplasia. So you can see some islands of resulting from the cross-section of overlying oral epithelium look like squamous cell carcinoma. Also, the ductal structure have metaplastic changes that can look like squamous cell carcinoma, but the absence of atypia can help you to differentiate between these two, and also you can the preservation of lobular architecture, and that is shown in these red arrows. What I've shown by red arrows is that the necrotic acini are vanished in some parts, and just the empty space of the acini is here, and this is called dropped out acini, which is also a feature of necrotizing cyalometaplasia. Also, I took this picture from Fletcher's diagnostic histopathology of tumors. So, absence of nuclear atypia can help you. There's another feature that can help you to differentiate it from mucoepidermoid carcinoma, that you don't have an island with intermixed mucus and squamous cells. There are some necrotic acini of mucus cells and separate islands of squamous epithelium. So one of the other differential diagnosis of the lesion is subacute necrotizing cell adenitis, which usually is seen in teenagers and clinically presents as a tender mass, usually in the hard palate. But the name necrotizing doesn't mean that clinically necrotic ulcer in the mucosa. The necrotizing word refers to necrotic acini that are present in this lesion. There is no pseudoepitheliomatous hyperplasia, no ulcer in this lesion that can help you to differentiate these two lesions, no ductal metaplasia. And it is a subacute cell adenitis. You have subacute inflammation, heavy inflammation containing some eosinophils. So I've said all the things in this slide. So Professor Slupek, maybe we can go to the next case.
Yes, but one point, I noted the question in the chat box about the so-called dropping off of the epithelium, dropping off of the squamous epithelium to the connective tissue, and I would like to emphasize that it is not really a dropping off, but as you described, is just a metaplastic change of the mucinous epithelium. So dropping off, that is something that we see in squamous cell carcinomas and so on, but here it's not, it creates the impression of dropping off, but it's not real dropping off. It is just a replacement of the remnants of the mucinous and ductal epithelium by squamous epithelium. That should not be labeled as dropping off, but should be labeled as a metaplastic change. That is the thing I think that we should address to avoid confusion about the meaning of dropping off. For otherwise, it's a very nice case, and I think you can continue in the next one. I don't see any other major questions.
Thank you very much for the comment. So case 3 is a 50-year-old male. He had a palatal mass, soft palatal mass with bluish hue for 5 years, and the differential diagnosis of the surgeon was pleomorphic adenoma and mucoepidermoid carcinoma. He performed an incisional biopsy, and this is the result. So you can see the overlying oral epithelium and the lobular aggregations of salivary gland. You can see that you can see that the lesion is elevated, and beneath it, you can see normal mucous salivary gland with some dilated ducts. This is another view of the lesion. This is a closer view. Just in some areas, a little inflammation, chronic inflammation, and nothing more except the dilation of the ducts. So what is your diagnosis? In this case, I don't have choices because I know that it's not very much difficult. So please type in the chat box what do you think about it. You want me to show you the slide?
What is your own suggestion? I see in fact, I see two things popping up. Most people think about an adenomatoid hyperplasia, and others are speaking about sialosis. I think sialosis is not an option because sialosis is mainly a secretion disorder in the parotid gland. And here we are looking at mucinous glands in the palate, and when you don't see any histological abnormality, as I do not see, but just an excess of normal tissue, in fact, yeah, the only option for me would be hyperplasia. But maybe you have another idea and I am caught in some pitfall.
I didn't hear it clear properly. You said the only option for you is
Please?
Can you repeat your choice, your answer?
I think the majority votes for adenomatoid hyperplasia. And I think I agree with that, ruling out sialosis, because sialosis is mainly a lesion in the parotid gland on basis of a secretion disorder. So in sialosis, the cells are enlarged, and and here in this case, I do not see any cell enlargement. It's just an excess of normal tissue, and that fits in the diagnosis of hyperplasia.
Yes, to me it looks also it looks like adenomatoid hyperplasia, and you know, because of its clinical presentation, it presents like a tumor in the most common site of involvement is palatal mucosa. And because of its clinical presentation, you need to perform a biopsy, but once the diagnosis is made, it doesn't need for further treatment. But I didn't show you all the slides. My apologies for being mean. There was a little area like this beneath the overlying oral epithelium. You can see a nodular area of hypercellularity and some duct-like structures. We only had this one, and the majority of the sections was what I showed you, and only in one section there was something like this beneath the epithelium. You can see this some duct-like structures and within a myxoid, almost myxoid background, cellular. So, you know, we all know the adenomatoid hyperplasia is a lesion that could be clinically mimic a tumor. But in case that in some cases there is a real salivary gland tumor, and when they want to perform the biopsy, they mostly harvest the adjacent normal salivary gland structures. In this case, the pathologist should be aware of that there might be the presence of a tumor near this area. To me, it really looks like hyperplastic because, you know, if you see this picture, the mucosa in some was elevated. So it looks to me that it was as a result of hyperplasia of these normal glands, but hyperplastic or not. Because I look at the literature, if I can find adenomatoid hyperplasia near another salivary gland tumor, I couldn't find. Hyperplastic or not, the most clinical significant lesion was the tumor that was near it. So because it was very small, and I asked for deeper section, there was almost nothing left. So I just made a note that there might be the possibility of adjacent tumor near the lesion, and then the surgeon excised the tumor, the lesion, and this is the excisional biopsy. Professor Stutek, may I continue, or you want to add some comments? Okay, I will continue. Here you can see a well-defined lesion that's lined with a thick capsule beneath the epithelium. And as you can see, there are some ductal structures lined by multiple layers. Here you can see that the stroma was, you know, fibrous in some area, but mixed in most of the parts. And a feature that I want to, and also you can see duct-like structures lined by multiple layers of mostly clear cells. And the abdominal cells supporting the ductal structure seems to be gradually melting in stroma. You could not draw a line and say this is the area of duct and this is the stroma. They will gradually melting into the stroma. Here you can see also the ductal and the melting the stroma appearance. There were also some plasmacytoid cells which are more frequent in the minor in the tumor of the minor lesion, minor salivary gland lesion. And of course, if you're lucky enough, you may see some chondrite material. So what I want to say in this case was that the importance of sectioning some lesions like adenomatoid hyperplasia in order to make sure that the biopsy was performed from the good site and there's no other lesion near it. Sometimes, you know, in this case, I remember I suggested the surgeon a rebiopsy, and he said I prefer to excise the lesion completely. And I have, and actually I've selected this case because it somehow connects between the non-tumoral and tumoral lesions, which I'm gonna share in the next session. So Professor Stutek, if there's any comment or question.
Yes, of course. It is a clear illustration that you should have always representative tissue to make a diagnosis. That's the first thing. And the other point is that that small area that you showed that was the clue. There was also some squamous metaplasia in it. And I think this, especially, we should realize that especially in palatal pleomorphic adenomas, when there is some ulceration, you can have squamous metaplasia within a pleomorphic adenoma, which may make you, can lead you astray in making a wrong diagnosis of squamous cell carcinoma of mucoepidermoid carcinoma. So when you having a palatal lesion, you not only should exclude necrotizing metaplasia, but also squamous metaplasia in some kind of salivary gland tumor. I think that's an issue that can be connected with this case.
Yes,
thank you.
Thank you very much, Professor. So I can see in the chat box that somebody mentioned epimyopathy.
Maybe I will interrupt. I see a very important question popping up. One person thinks that incisional biopsies are not indicated for suspected salivary gland neoplasm. That is true, but that also counts for the major salivary glands. For the intraoral salivary gland tumors, you also always have to take a incisional biopsy, because in that case, aspiration cytology is quite often unsatisfactory. So that's a comment on basis of one of the chat questions. Thank you.
Thank you, sir. So I'm done with the first part of my presentation. If you think we could have a refreshment, and then I will continue with the next part. So maybe have a refreshment, a 5-minute refreshment, and then
you have to finish your case presentation. You finished your case presentation.
Yes.
Okay, then we can have. I think we can have now take 10 minutes break. A 10 minutes break, and then we will return for your next presentation. Okay.
Thank you very much, Professor.
So we'll be back in 10 minutes. Well, sorry for that, all those nice videos, but I think we have seen, in the meantime, seen quite a lot of Iran, and now we can continue with the salivary gland task. I noted some questions about cytology, in the value of cytology in case of salivary gland pathology, but I think I would like to postpone that point also for the presentation of Professor El Nagar, because he will address that issue as well. And therefore, I think we will now continue first with the next presentation of Dr. Aravi on the clear problems that we can have with clear cell changes in salivary gland tumors. So I hope that that problem will now be made clear to us. The floor is again yours, Dr. Madavi.
Thank you very much, Professor. Yes, here I will talk about some salivary gland with clear cell changes. You know, in the head and neck region, different tumors of epithelial, mesenchymal, melanocytic, or even hematopoietic derivation may show clear cell change. But now in this presentation, I'm going to focus on the clear cell tumors with salivary gland origin. In salivary glands, almost any cell type, including acinar, ductal, and myepithelial cells, can show clear cell changes. And it's usually not easy to perform the diagnosis based on the pure H&E slides. You know, besides careful examination of the H&E slides, you may need for histochemical, immunohistochemical, or even molecular analysis. In this presentation, I will share you some cases with of salivary gland tissues with prominent clear cell changes. So the first case of this part of my presentation is a 19-year-old lady. She had an ulcerated mass on the right hard palate. The lesion was 4 centimeters. She had the lesion for 2 years. And the differential diagnosis of the clinician was pleomorphic adenoma. This is the incisional biopsy performed, and it was an incisional biopsy, but of course I had adequate tissue in this. So here you can see, you know, large sheets of clear cells intermixed with some cells with eosinophilic cytoplasm, and there was also some cystic spaces that I show them with these blue arrows. Here is another view of the lesion. Here you can see the admixture of clear cells and some cells with large eosinophilic cytoplasm. And if you want to see more details, you can see that they look bland appearing. The border of the clear cells are distinct, and the squamous cells the squamous appearing cells also look have vesiculated nuclei, and no atypia is seen. This is another view of the lesion. So here you can see that you know, almost the entire lesion was looking like this. Clear cells with distinct cell border intermixed with some cells with eosinophilic cytoplasm. Scattered mucus-like cells was also present, and some like structures was also seen. There were also some cells like this, where smaller cells. And in this case, you can see in the upper side of the picture scattered mucus cells, and of course in that bottom side of the picture, there are some regional acini that could be seen in this picture. So we asked for a deep section because the sampling was, was almost adequate. So in the deep section, there was more cystic structures that you can see one here. And inside the cystic structures, I saw more mucus cells lining the cysts. And then after this, we asked for more deep sections, and this is what we got after some deep sections. Here you can see some more cystic spaces that were lined by mucus-like cells, and these cells were, some of them were tall, goblet-like cells. And so in this case, actually, we were lucky. Many times I asked for deep sections, sometimes in order to see whether there's a cystic epithelium. Sometimes I find it, sometimes not. But this is one of fewest times that I was so lucky to see the very helpful feature in the deep section. And I want to know your opinion. What do you think the diagnosis is? Mucoepidermoid carcinoma, 2 clear cell carcinoma, and 3 clear cell variant of squamous cell carcinoma.
Well, when looking at the chat box, the majority votes for option 1, mucoepidermoid carcinoma, and I think indeed that's the right diagnosis. But, I would like to make some comments on the other options. Let's say option 3, the squamous cell carcinoma, I think can be ruled out because we see squamous cell, we see mucus cells, and we don't see any keratinization. And for a squamous cell carcinoma, you should see, at least in some areas, some keratinization, individual cells or some keratin bodies, and keratinization absent in this case, your own case, when it's present, rules out mucoepidermoid carcinoma, because in mucoepidermoid carcinoma you almost never see any real keratinization, only spinous differentiation. And option 2, a clear cell carcinoma, yeah, that's a diagnosis by exclusion. You can also only make a diagnosis of clear cell carcinoma when you don't see any features of another salivary gland carcinoma. Or another option is that you have available the genetic, the option to do molecular pathology, because clear cell carcinomas, they have a specific genetic change, a translocation in the EVS fusion gene. For more information, I refer to the literature. So in principle, when you are limited in your lab options, clear cell carcinoma is a diagnosis of exclusion, no myoepithelial differentiation, no mucus differentiation, and that rules out. And when you don't see any features of something else, then you can say clear cell carcinoma, probably to be confirmed by a molecular diagnosis. So in this case, spinal differentiation and mucus cells both are point to a diagnosis of mucoepidermoid carcinoma. And the questions are some questions that I would like to address. Clear cells do not affect histological grade, but I can say that they are mostly seen in low grade. In low grade mucoepidermoid carcinoma, in intermediate and high grade, we don't have clear cells in general. And the criteria for a diagnosis of clear cell carcinoma I already have briefly mentioned. Genetic changes in absence of any other immunohistochemical profile, and there is a squamous cell carcinoma with clear cells but without keratin bodies. That's a theoretical possibility, but that doesn't play a role in practice. So far, my comment on this case and the questions that have arrived. So, as far, for me, you can go ahead to the next case.
Thank you very much, Professor Slootweg, for your nice comments. Yes, it is mucoepidermoid carcinoma. You know, we were lucky to have the typical feature of mucoepidermoid carcinoma in the deep sections. It is a tumor admixture of epidermoid, intermediate, and mucous cells. It has some other variants, clear cell, oncocytic, and you know, it is considered the most common malignancy of salivary glands, irrespective of the sites, and it has shown to have a translocation CRTC1 mammal2, and also in some cases TC3 mammal2, which this looking for this translocation, as you mentioned, Professor, can be helpful in difficult cases. This is one of the earliest reports that reported the presence of this translocation in mucoepidermoid carcinoma, written by Professor El-Najjar and Associates. And then this translocation was also shown in other, in Wartin tumor. Also, this article is written by Professor El-Najjar and Associates. Regarding its histochemical profile, cytokeratin 7 are considered to be show strong positivity in these cells. What I want to mention is that we were lucky to have the typical feature of mucoepidermoid carcinoma in this case. But if the whole lesion was looking like that, what was seen in the first sections, that could be a challenge for the diagnosis. And I think that needs for ISC studies and further evaluation of the lesion. And I have a question from you, Professor Slootweg. I've seen in some literatures and also in some textbooks, and I saw that somebody mentioned this also in the chat box, that the presence of goblet cells is specific for mucoepidermoid carcinoma, though the presence of scattered mucous cells is not specific for it and can be seen in other lesions. The goblet cells are specific for it. And if you see goblet cells, don't think about, for example, clear cell carcinoma. Is this correct? So in this case, I saw goblet cells, and it would be helpful for me. But I want to know your opinion. Is it correct?
No, not sure, because you can have both clear cells and PAS positive goblet cells also in pleomorphic adenoma. So that's the main differential diagnosis. When you have a palatal pleomorphic adenoma, in which you can have clear cells, you can have mucinous cells, and you can have squamous metaplasia. So sometimes it's quite difficult to make a distinction in palatal biopsies between a low-grade mucoepidermoid carcinoma and a pleomorphic adenoma, and that's and then you have to postpone your diagnosis till you have seen the whole specimen, because for the treatment it doesn't make any difference. Both the pleomorphic and the palatal pleomorphic adenoma, as well as the parietal mucoepidermoid carcinoma, and it should be taken out with a margin of normal tissue. And then you can, afterwards, when you have the entire specimen, then you can make the correct diagnosis. But be aware of that pitfall. Goblet cells are not unique for a mucoepidermoid carcinoma. They are can also be found in mucinous cyst adenomas as well. Okay?
Yes, thank you very much. Thank you very much for your time. So, if the case was looking like the first section, looking like the sheets of clear cells intermixed with some eosinophilic cells, then it has a broad differential diagnosis from myoepithelial carcinoma to clear cell carcinoma. In myoepithelial carcinoma, the presence of myopithelial markers could be helpful, and which is not expressed in mucoepidermoid carcinoma. One of the other differential diagnoses that some people mentioned is clear cell carcinoma metastatic, which has also some features with similar features with this lesion, including clear cells, but the stroma is vascular rich, including some sinusoidal vascular, which was not seen in our case. Also, in challenging cases, you can use IHC. In clear cell renal cell metastatic carcinoma, cytokeratin 7 and P63, which are strongly positive in mucoepidermoid carcinoma, are negative, and high molecular weight cytokeratins are also negative. In the other hand, CD10 is positive and vimentin is positive in this tumor. So if there's no comments, maybe we can go to the next case.
Yeah, sure.
So this case was a 64-year-old lady. She had a posterior hull palatal swelling, and she wasn't aware of the lesion. Actually, it was found during the routine dental examination. And they performed an incisional biopsy from the lesion. Here is what you can see. The overlying oral mucosa, oral epithelium shows pseudoepitheliomatous hyperplasia, and beneath the epithelium there is a lesion seems to be composed of clear cells. This is another view from the lesion. Here you can see some clear cells, and within a stroma showing some separated by hyalinic septa. But most of the lesion looks like this. Here you can see small nests, and there was also some small cords of an admixture of clear cells and some cells with eosinophilic, small eosinophilic cytoplasm, and the stroma was, seems to be hyalinized. Here is a more closer view of the lesion. Here you can see clear cells within the form of some nests and islands with different size. Some of them are small, some of them are larger. The stroma seems to be hyalinized, and you can see also some small cells with eosinophilic cytoplasm too. Here is a more closer view of the lesion. If you want to detail the cellular characteristic of that tumor. This is how the clear cell looks like. They had distinct cell border with kind of bland appearing nuclei, and also the stroma was highly nice in this site, but also there were areas with, somehow myxoid stroma. And here you can see that an island of the lesion that infiltrating into the muscular layer. So, what is your differential? What is your differential diagnosis? And of course, we performed some ICs for this case, but in order to design an IC panel, you need to have some differential diagnosis. These are my suggestions. Which is your choice, or which ones are your choice?
Well, looking to the chat box, I am a little bit impressed because I see so many diagnoses and people are calling about an myoepithelial carcinoma. But for an myoepithelial carcinoma, we need to see some ductal differentiation and the clear cells that are the predominant feature in this case, they should be arranged as cuffs surrounding a duct. And in the slides that you have shown thus far, I didn't see any ductal differentiation. Of course, ductal differentiation may be minimal and may need some immunohistochemistry to be demonstrated, especially cytokeratin 7. But for the major point, it's only clear cells. So that means that we should look, what are those clear cells? Are they, I don't see any goblet cells, so I don't think they are just, they are not changed mucus cells. So the other option is to rule out a myoepithelial nature. And that, of course, requires, as you already told, the P63 immunohistochemistry. And if that's negative, then, yeah, maybe you can, at first you can show what you have done thus far by immunohistochemistry. I think there's something wrong. Okay, now
yes, there's something, and the IT team is trying to correct the problem, solve the problem. Okay, so my apologies, Professor. Please continue.
Now I see some other diagnoses popping up. The hyalinizing clear cell carcinoma that we already briefly discussed. So maybe I think you can go ahead with this case, and then we will come back to the different issues afterwards.
Okay, thank you very much, Professor, for your comments. These are the immunohistochemical staining of a lesion. This is cytokeratin 7 staining, which you can see that it was immunoreactive for cytokeratin 7. Most of the cells.
Yes, but as you can see that the positivity is uniform in the nests. So there's no, the cells are decorated, but there is no ductal differentiation visible. It's just solid sheets. Yes?
This is, this is cytokeratin 14, which is considered a high molecular weight cytokeratin, which is also expressed in this tumor. This is P63 staining. This is S100, and you can see it was negative for S100. It's CD10 staining, which you can see it's negative for CD10 in order to rule out metastatic renal cell carcinoma. And this is grade 67 staining of the lesion. So maybe we can have the audience's opinion after this immunohistochemical studies. What do you think now about the diagnosis?
Yes, well, I think now I see some points popping up. I think that is more illustrative. But maybe you can tell us, you can have also seen the chat box. For me, it would be a hyalinizing clear cell carcinoma.
Yes.
But if possible, confirmation by molecular biology.
Yes, you're correct, Professor. Based on this immunohistochemical profile, we suggested the diagnosis of clear cell carcinoma because, as you could see, high molecular weight cytokratins and P63 were positive in this tumor. And in this case, P63 staining was not indicated of myoepithelial differentiation, but squamous differentiation. As you could see, high molecular weight cytokratins, cytokeratin 14 was also positive in the tumor, and S100 was negative. Case staining 67 staining also shows, less than 10% in hotspot. So this is the suggestion. Of course, I didn't have access to molecular analysis, so I cannot perform definitive diagnosis for the case. But based on the histological and immunohistochemical study, the diagnosis of clear cell carcinoma could be suggested, which is most commonly occurring in minor salivary glands. And the outcome of the tumor is excellent. Maybe sometimes it recurs or regional metastasis could be seen, but distance metastasis is not a common feature of this tumor. So as Professor Slutbeck mentioned, it has a diagnosis based on the exclusion of other lesions. You need to exclude the presence of myoepithelial cells, and then and on other tumors in order to perform the diagnosis of this tumor. So these are this is a dream picture of clear cell carcinoma for pathologies. You can see clear sheets and small islands of clear cells within a hyalinized stroma. But what you can see most of the times is that the lesion, most of the cells appear, you have eosinophilic cytoplasm, and there are scattered cells with clear cells in this tumor. The stroma is characteristically hyalinized, but also you may see some areas with myxoid appearance. Here you can see two types of the stroma. I took these pictures from a brilliant article which I addressed beneath the picture. And this is considered a low-grade tumor, a low to intermediate grade tumor, but it you can see that in many times you can see that the tumor infiltrates between the skeletal muscle, which in this feature is considered as a malignant or aggressive behavior in many tumors. It is a low-grade tumor, of course malignant, but low-grade tumor, this is a common feature of it. Also, in half of the cases, the lesion is connected to the overlying oral epithelium, and pseudoepitheliomatous hyperplasia is also a common feature. But of course, this is not a characteristic feature for this lesion. Perineural invasion is seen in half of the cases. And I would like to emphasize of what Professor Slutbeck says regarding the absence of ductal differentiation in these tumors. Sometimes you can see the regional remnants of the ducts, but these are not true ductal differentiation of the tumor. These are the regional ducts that are entrapped within the tumor. And they're mostly seen in, this is the tumor of mostly seen in minor salivary glands, but this feature is mostly seen in the major salivary glands. This is the immunohistochemical profile of the lesion. Pan-cytokeratin as cytokeratin 14 and P63 are markers that are almost always positive in these tumors. And in the other hand, myoepithelial markers, as Professor Slutbeck mentions, are negative in this tumor. These are S100, SMA, MSA, GFAP, and calcitonin. You need to rule out the presence of myoepithelial cells in order to perform the diagnosis of hyalinized clear cell carcinoma. And in this regards, I want to mention that regarding the myoepithelial cells, we do not have a single marker that highlights all the myoepithelial cells. So you may have myoepithelial cells that do not stain with some of these markers. So in order to rule out the presence of myoepithelial differentiation, you need to choose a number of these markers. So, one of the most challenging differential diagnosis, it has a broad differential diagnosis, but one of the most challenging differential diagnosis of this lesion is mucoepidermoid cell carcinoma, clear cell variant, and myoepithelial carcinoma, and I could see that some of our colleagues performed the diagnosis of myoepithelial carcinoma, which we can also talk about. So the reason it comes to the differential diagnosis with mucoepidermoid carcinoma is that they have some common features. They both have mucous cells and clear cells, and also some eosinophilic cells, and we know that the presence of mucous cells, regardless of its number, does not rule out the clear cell carcinoma. And these are the features that could be helpful in differentiating these tumors. Mucoepidermoid carcinoma is usually arranged and likes to make cyst areas. So it has greater tendency for cyst formation. In the other hand, cyst formation is not a common feature of clear cell carcinoma and usually forms small nests and thin cords. On the other hand, sclerotic hyalinized stroma is a feature of clear cell carcinoma, which is not a common feature of mucoepidermoid carcinoma. So I've written the presence of goblet cells, which could be helpful for the diagnosis of mucoepidermoid carcinoma. But as I found it in the literature, but as I had a conversation now with Professor Slutbeck, it doesn't seem to be a characteristic view of mucoepidermoid carcinoma. So I should put it out from this list. And perineural invasion is a common feature. Regarding the necrosis, there are disagreements in the literature. So I also found some interesting articles claiming that they have evaluated many of the previously diagnosed clear cell mucoepidermoid carcinoma for that translocation of mucoepidermoid carcinoma and also EWSR1 translocation for clear cell carcinoma. And they found that many of the cases that were previously diagnosed as mucoepidermoid carcinoma were actually hyalinized clear cell carcinomas. So maybe we should be careful when we want to perform the diagnosis of clear cell carcinoma versus clear cell type of mucoepidermoid carcinoma. One of the other differential diagnoses is clear cell myoepithelial carcinoma or clear cell myoepithelioma. And as mentioned before, the presence of they share basal and squamous immunohistochemical positivity. Both are positive for p63 and high molecular weight cytokeratin. You know, the presence of the p63 staining in myoepithelial tumors indicates the presence of myoepithelial differentiation. On the other hand, we know that this marker is not specific for myoepithelial differentiation. In some cases, it indicates the squamous differentiation, like in hyalinized clear cell carcinoma. So this feature may lead to misdiagnosis. And also the presence of myoepithelial markers in some myoepithelial tumors could be patchy or variable. You know, not all the myoepithelial tumors stain with all the myoepithelial markers. So that could be also the matter of challenge in some cases. And also, some of the myoepithelial tumors may have EWSR1 translocation as well. But there are features that could be helpful in the differential diagnosis of these. A panel for myoepithelial markers, including S100 and actin, could be helpful in differentiating these two tumors. And also hyalinizing clear cell carcinoma, or as what WHO classification mentioned, clear cell carcinoma is a tumor that usually arranged in small cords and small nests and thin cords. And you know that the same translocation was also found in clear cell odontogenic tumor. And I found this interesting article written by Professor Slutweg and associates that same clear cell odontogenic carcinoma may have other translocation alternative to the fusion of EWSR1 ATF1.
Yes, the point is indeed that you have very well addressed the problems of the clear cells in salivary gland tumors. But regarding myoepithelial carcinoma, maybe I have one additional note. That is that myoepithelial carcinomas usually are high-grade lesions. High-grade lesions that have a lot of cytonuclear atypia, whereas the hyalinizing clear cell carcinoma usually doesn't have very prominent atypia. The cells are usually bland and monotonous. So when you see a high-grade tumor with a lot of mitotic figures, a lot of nuclear pleomorphism, necrosis, and so on, and clear cells, it's much more probable that it is a myoepithelial carcinoma and not a hyalinizing clear cell carcinoma. That may already be a first and quite easy point to help to make the distinction between both possibilities.
Thank you very much, Professor. I found a question in the chat box, and the question is how to differentiate between clear cell odontogenic carcinoma and hyalinizing clear cell carcinoma. And my question is it necessary to differentiate between these tumors?
Yes, but it's mainly a question of location. The point is, there are people who say it's quite possible that it's the same lesion, only in one case arising in the soft tissue, the salivary glands, and another point arising in the bone. So when you have just a biopsy and you don't know where it comes from, either from salivary gland or from within the jaw, yeah, you are yeah, you remain confused. So we need clinical information about the site of the lesion to make the distinction. Yes. That answers your question?
So is it any clinical significance for the patient to make the diagnosis of high-mass clear cell carcinoma over clear cell odontogenic carcinoma? Do they have different outcome or the need for different treatment?
No, as far as we know now, because the case that's a rather uncommon lesion, but for the time being, they should both be treated as a malignant lesion, and there is no targeted treatment, so it is just surgery. And for the treatment, it doesn't make much difference.
Thank you very much, Professor. If there's no comment, maybe I can go to the next case. This case was for its 42-year-old female with a chief complaint of a swelling in her palate. She had this lesion for almost 3 years. The patient was non-smoker, non-drinker, with no history of a systemic disease. The clinical examinations of the lesion revealed that there was a nodular mass 2 centimeters on the hard palate, and the overlying oral mucosa was intact, no ulceration. The lesion was normal in color. It has soft tendency. No, it was not tender in palpation. There was no pain, no paresthesia or dysphagia. And on palpation, there was no evidence of lymphadenopathy. The surgeon performed an incisional biopsy from the lesion, and this is the low power view of that lesion. You can see that it is in this area, it is lined by a thick capsule. This is another view of the lesion. You know, if you want me to explain what I saw under the microscope, because I don't know if you can see it clearly or not, but I have 2 different devices that they show me 2 different pictures with 2 different views. In one of them, I can see the pictures clearly, in the other not. So I don't know which of one do you, how do you see this picture? So I want to explain what I saw in that light microscopical examination. So it was, large lobular aggregations of a mixture of eosinophilic cells and clear cells. And there were some areas that I pointed out here. They would look like, some ductal differentiation. Here's another area with more high power view. Here you can see that the stroma was hyalinized in some parts, and there was also some areas with myxoid background. And you can see the cells. There were most of the cells actually were pale staining cells. With pale eosinophilic cytoplasm, and there was also, if I have a closer picture, yes, this ductal differentiation also seen this picture. So there was some, globes of hyaline material, and also some concentrated nuclei in some areas. This picture is from the periphery of the lesion, near the capsula. As you can see here, there are some ductal differentiation. And I'm going to show you a more closer view of the ducts. These are what we saw under the microscope. Here you can see some duct-like structures within a hyalinized stroma. You can see the luminal cells are the luminal cells are small cuboidal cells with eosinophilic cytoplasm, and they are supported by an abluminal cells of some cells with larger clear cytoplasm. In some parts, they were supported by one layer of these cells. In other area, there were two or three layers of these clear cells supporting that ductal structures. So we performed some IHC for the lesion. This is Gal-67 staining. It's almost negative, except for some little areas. So here P63's staining. So this is P63. You know, the lesion was, you know, histologically it looks like that it had two counterparts. And in one area we had some duct-like structures, but in most of the lesions there were lobulated you know, aggregations of a mixture of clear and eosinophilic cells. So this P63 staining, I took this picture from the you know, lobulated sheet-like area. This is the P63 staining results from the area with ductal differentiation. As you can see in this picture, this is the ductal cells, the luminal cells, but do not stain for that P63 markers, and the abluminal cells that show positivity for P63. This is another view for this. As you can see again, the abluminal cells are immunoreactive for this marker. This is cytokeratin 7 staining results. As you can see, you could see scattered areas with cytokeratin 7 positivity. But you know, most of the cells did not stain with cytokeratin 7, but do show immunoreactivity for P63. And this is the ductal area. Here you can see that the luminal cells stain with cytokeratin 7, and the abluminal cells show no staining for this marker. So what do you think the diagnosis is?
Most people vote for option 1, epithelial myopathic carcinoma. I think I would concur, but I'm a little bit worried because it's so very, very monotonous, and so not so much mitotic figures, a very low Ki67 number, and that makes me a little bit worrying about another option that you did not include, a cell-rich pleomorphic adenoma as other option. It's not a myoepithelial carcinoma because there's ductal differentiation. There's not a hyalinized clear cell carcinoma for the same reason, and there's also not an adenoid cystic carcinoma because the ductal component is too prominent. So for me, differential diagnosis is between epithelial myoepithelial carcinoma and cellular pleomorphic adenoma.
Yes, Professor, thank you very much for your comments. As you mentioned, the Ki67 staining was so low. Of course, the picture was taken from with areas with very low immunoreactivity. Regarding the Ki67 staining, the overall immunoreactivity in whole lesion was almost 7%.
Mm-hmm. The other option from the list is polymorphous adenocarcinoma, but that could also be an option. I cannot see from the slides shown thus far. If that, but that may be a third consideration. But sometimes you have to, from this area, here I think indeed epithelial myoepithelial carcinoma, but sometimes it looks as if the myoepithelial cells are just lying dispersed, single in a matrix. And that's more typical for a pleomorphic adenoma. For one of your first slides.
Yes, please.
Maybe you can go back to other slides a little bit. Yes, this area here. Here you see a kind of spindling. And this spindle area, that's more suggestive for epithelial myoepithelial carcinoma, this area. So I think, look at this, EMC, that would be my favorite outcome. My favorite outcome. Yeah.
This was suggested by us too, but you know, it is a low-grade tumor. It's almost rare and represents 1% of salivary gland neoplasm, and over 75% of these lesions occur in parotid glands, so it's not common in minor gland as in our case. It's twice common in women. And so I will talk a little bit about its histological characteristics. Then I have some questions from you, Professor Stutek, that be much appreciated if you could help me with this. So regarding this histopathological features, you can see in low power, you can see that it has multinodular growth pattern, and at least partially, you can see a capsule. You can see both ductal and myoepithelial differentiation, and also some naked nuclei within the stroma and hyaline globes are some histological features that could be seen. The hallmark, histological hallmark of the lesion is the presence of double-layered duct-like structures. The inner layer are cuboidal duct-like cells, and the outer layer is myoepithelial cells with clear cytoplasm. You may have one layer or multiple layers of large clear cell myoepithelial cells lining supporting the duct cells. So these are the differential diagnoses of the tumor, because it has some clear cells. The tumors with clear cell change came to the differential diagnosis. And because it has ductal structures supported by myoepithelial cells, so some tumors, including pleomorphic adenoma and adenoid cystic carcinoma, comes to the differential diagnosis. One of the features that could be helpful in differentiating this tumor, so I'm not sure about it, and I'd like to know your opinion about this. Some authors, in some articles, I found that some authors say that one of the features that could be helpful in differentiating pleomorphic adenoma from epithelial myoepithelial carcinoma is that the myoepithelial cells in the pleomorphic adenoma gradually melts in the stroma. However, in the epimyoepithelial carcinoma, there's a distinct border between the stroma and myoepithelial layer. So can we use this criteria as a diagnostic aid to differentiate between pleomorphic adenoma and epithelial myoepithelial carcinoma, Professor Stutek? I'd be happy to know your opinion about this.
Yeah, I think you have here a very good and concise overview, clear cell change, but as you already told in one of your earlier slides, with different ductal component, you have also be very careful that you are not looking at pre-existent ducts that are engulfed by surrounding tumor tissue. And so always be sure that you are not misdiagnosing pre-existent ducts for a ductal component of a tumor. And of course, as I told you, here the clear cell change between the hyalinizing clear cell carcinoma, myoepithelial carcinoma, that's the presence of myoepithelial markers and the difference in pleomorphism, myoepithelial carcinoma being showing much more pleomorphism than hyalinizing clear cell carcinoma, and at the other side, adenoid cystic carcinoma doesn't show the lack of cellular cohesion. And the pleomorphic adenoma features a lack of cellular cohesion by which the myoepithelial cells are surrounded by their own matrix, lying single in the matrix. And adenoid cystic carcinoma, you never see that that dissolution of cellular areas into single cells. That's also a very important diagnostic feature that helps to distinguish between adenoid cystic carcinoma and pleomorphic adenoma.
So can we use the presence of cribriform appearance?
Yes, but cribriform areas you can also find in the polymorphous adenocarcinoma. So cribriform areas, of course, are most typical for adenoid cystic carcinoma, but not unique. That's the point.
Mm-hmm. So can we use it to differentiate epithelial carcinoma from adenoid cystic carcinoma? If we see this feature, we can exclude epithelial carcinoma?
Yeah, yes, but they show some overlap. They show some overlap. I think maybe we can postpone that questions after the lecture of the next speaker, because I think he will address some of those issues as well.
Yes.
And now leaving, you gave a very good overview about on the area of the clear cell changes in salivary gland tumors, emphasizing that as first you have to rule out clear cell change in a specific entity, myoepithelial carcinoma, adenoid cystic carcinoma, pleomorphic adenoma, epithelial myoepithelial carcinoma, and then mucoepithelial carcinoma as well. In fact, most salivary gland tumors can show some clear cell change. So presence of clear cells always requires a lot of tumor sampling to exclude an underlying pre-existent lesion with secondary clear cell changes. And if you have ruled out that possibility, then you can start thinking about hyalinizing clear cell carcinoma. I think that's the main message.
Thank you very much, Professor. So another question is that do the melt in the stroma appearance of the peripheral myoepithelial cells, which is seen in pleomorphic adenoma, that myoepithelial cells gradually melt in the stroma, and there is not a distinct border between myoepithelial cells and the stroma. And in epithelial myoepithelial carcinoma, there is a distinct border between the stroma and myoepithelial cells. I've seen some authors suggest this feature as a criteria to differentiate between these tumors. Is it a good criteria to use?
Yes, as I told you, in fact, indeed, the epithelial myoepithelial carcinoma shows a lobular, nodular architecture, and the cells, they keep their epithelial adhesion, epithelial configuration. And when that epithelial configuration is lost, because cells are now getting loose from each other, then pleomorphic adenoma enters the differential diagnosis.
Mm-hmm. Thank you. Thank you very much, Professor, for this valuable comments. So on conclusion, so here I present 3 cases with clear cell, prominent clear cell changes. And as conclusion, I would like to mention that clear cell tumors of salivary gland are a diverse group of benign and malignant tumors with variable clinical pathology characteristics. In order to perform a diagnosis, a distinct between these tumors, you need for careful examination of H&E slides. Sometimes you need for more sections or even an extra biopsy. And in most cases, you need for histochemical, immunohistochemical, and probably molecular studies. So I would like to thank you very much, Professor Stutzbeck. That was really, really very informative for me, what I got from your comments. And we have here in this virtual room eminent professors and outstanding pathologists from different countries around the world. I would like to thank them all for your time and consideration. And also, we've received some emails with some questions regarding the histochemical profile of normal salivary gland tissue, and also some signaling pathways of salivary gland tissue, which was not relevant to this lecture. So I didn't mention the questions. So I will, of course, send an email to you, and I will answer the questions as soon as possible. So thank you again, Professor Stutzbeck, and thanks for the audiences.
Thank you, Dr. Madhavi, for your very instructive and practically oriented talks this afternoon. For me, at least for me, afternoon, for you already evening. And I think I see a look at the chat box, and I see quite a lot of positive comments. People thanking you for your efforts and for your anything you have said to be of help in this difficult area of salivary gland tumors. And so we have now had 2 of the 3 talks for this afternoon, and I see already the 3rd speaker on the screen, Professor El Nagar from Houston, Texas. But I think we have 5 minutes left, and then we will, at the scheduled time, start with the last presentation in this salivary gland course. And in the meantime, I would like to say that I'm very happy to see Professor El Nagar, because he's from Texas, Houston, and we have read quite a lot in the papers about the power problems, and I was wondering if he would not have been frozen in the meantime in the very low temperatures there, but I see that he's still healthy and happy, so we are looking forward to his presentation.
Yes, well, it was power and water. So
yes.
So it was a difficult time, but the last 2 days everything is okay. Thank you, Peter, very much.
Okay, now we will back in 5 minutes for so okay. We can just relax, recollect our brain power for a few minutes.
Thank you.
So I would like to say hello to Professor El Nagar and thank you for accepting our invitation.
Oh, yes.
Okay, now we are back for the third presentation in the salivary gland course of this afternoon, evening, and it is my honor and pleasure to introduce Professor Adel Al-Nagar from the MD Anderson Hospital, Houston, Texas. We know each other already for a couple of years, and we had the privilege to be both on the WHO committee for the last edition of the Blue Book, in which Adele chaired the working group that had the duty to devise a new salivary gland classification. I can reassure you that whereas odontogenic lesions are a contested issue, salivary gland lesions are a much more contested issue, but happily he has survived that journey, and we have been able to produce a new and since then already quite often contested classification, but nevertheless we still are convinced that our classification is the best classification obtained ever. Do you agree, Adele?
Yeah.
Of course,
Yeah.
Adele has lectured and lectured on head and neck pathology and written over 700 papers and co-edited several books. So he is one of the icons in the field. And I think it's my great, I told already, it's my pleasure and honor to ask him to share his most recent thoughts on salivary gland pathology with all of us. Adele, it's your turn.
Thank you very much, Peter, for this introduction. And I also would like to thank Dr. Shakib and Dr. Mahadi for the invitation to present in your conference. As Dr. Slitwig said, we have worked together to put the WHO classification, and we both survived a lot of controversy, but as he indicated, I think we did the best we can, completely and impartially for the benefit of the pathology worldwide. We took ourselves from the authorship, so we were completely free to address issue without any prejudice. So with that, I thank Peter for coordinating this session and highlighting some of the issues with salivary gland diagnosis and differential diagnosis. What I will do is a kind of a broad bird eye view of salivary gland development and how that will impact on tumorigenesis, theory of tumorigenesis that impact on the classification, and then the practical part of the pathologic evaluation of salivary mass. I'll start with where salivary gland develop. We have three pairs of large or major salivary glands, and they develop early in the gestation. The first is the parotid. We're about the 5th to the 6th week of gestation. After that would be the submandibular and the sublingual, and then along with them numerous minor salivary gland tissue. The derivation from these pouch may impact the tumor distribution between these tissues and also glands. So the second is from the primordial cord, which is an epithelial cord in the second and the third pouch there would be an indentation early, and that indentation will proceed within the mesenchyme, and then branching occur without any canalization. And then later on, there would be a canalization of the ducts and the acini, ending with this, what we call a branching morphogenesis. And it's a process that's not unique to the salivary gland. It's in any kind of organs that have multitude of function with a very small space to do. Prostate is one, and kidney, another one, and breast, which is identical with the minor differences from salivary gland tumor. So branching morphogenesis is a very highly coordinated process that involves different factors, some of them known, numerous are unknown, and these lead to the proper development of the salivary gland and other organs that are initiated by branching morphogenesis. The end result of that process is what we call the ductal acinar unit. And the ductal acinar unit are divided into different segments, and these segments based on the cellular composition and features within each one: secretory, striated, intercalated, and the acid. What is unique about this acinar unit is the participation of the myoepithelial cell in only the smaller ductal component prior to the acini. So we don't see any participation of myoepithelial cells in the main duct, only in the segmental intercalated duct and the acini. And that will have also impact on the classification of these tumor later on. So this will lead to three major glands, pairs of glands: parotid, sublingual, and submandibular, and then numerous minor salivary glands distributed throughout the head and neck. In the parotid, the vast majority of tumor, although it's the biggest gland, are benign, and high percentage of sublingual and submandibular and minor salivary gland are enriched with malignant tumor. We don't really know the causes or the reason, specific reason for this, but we think that maybe the mesenchyme and interaction with the parenchyma from the second parenchymal pouch may have some effect on the mixture between the acini and the mucinous component, and that sublingual and submandibular are predominantly mucinous, and maybe the interaction between the mesenchyme and the ductum can promote more malignant than tumor. But this is hypothetical and it's not proven well scientifically. What is more kind of a side issue, it's a rare, but for the audience to recognize, there are numerous heterotopia that occur mostly in external auditory canal, the anterior part and the submental part of the neck, and then suprasternal. You may find these cases. At Anderson, because we see a lot of cancer, and odd one, sometimes we get odd presentation of salivary cancer at these locations. And usually they are considered metastases until proved otherwise. And since nothing primary in the minor or a major glands can be found, we think that these are have arisen from heterotopia. They can present as a small nodule, they can present as a cyst, and they can present as a sinus. The majority is benign tumor origin or development, and then cancer can also develop at these locations. So back to the ductal acinar unit, and that is the basis with what we think the origin, development, and classification of salivary gland cancer. And you can just focus on that terminal duct acini, and then the striated and the rest of the duct. About 20 years ago, we postulated that tumor development in salivary gland mirror their origin from the ductal system. So adenoid cystic carcinoma most likely will develop from here. Epimyoepithelial carcinoma and other myoepithelial-rich tumor will develop from here. Oncocytic and other ductal mucoepidermoid will all develop from larger segment of the duct. We hypothesize also that the tumor will develop from either an early uncommitted progenitor residing at these different locations. And if tumor developed in a very undifferentiated early progenitor, it will lead to cyanoblastoma and undifferentiated carcinoma. If the genetic event or the tumorigenic event occurred in a second stage, which in progenitor that have bipotent capability of differentiation, then tumor may develop in this one, and that would be the ACC and other dual cell formation, and also the basal cell tumor, which I will touch on later. So bipotent progenitor can lead to basal cell tumor and to epimyoepithelial carcinoma. There is also another direction where the progenitor is more differentiated or more committed to be myoepithelial, which can lead to myoepithelial tumor, or to an epithelial progenitor with no participation or involvement of the myoepithelial cell, and this would lead to mucoepidermoid, adenoid cystic, and salivary duct carcinoma. So that's broadly the hypothesis, and so far empirically that fit what we see in here. So back to just to remind you that a lot of subtypes and probably divisions that we tried at WHO to minimize and make it absolutely necessary to add or extract any subtype based on the clinical relevance and what the clinician would do. So with that in mind, we made very few changes in the classification, and these are the most prominent one. We thought that polymorphous adenocarcinoma are not all low grade, and some of them metastasize and kill the patient, so we omitted low grade. With the fusion and the identification of secretory from arsenic, we made a specific tumor type of secretory carcinoma. For carcinoma, X polymorphic adenoma was a generic term used for diagnosis without specification, and we thought that carcinoma X polymorphic adenoma need to be classified into subtypes: salivary duct carcinoma, myoepithelial carcinoma. So it would be advisable to say carcinoma X, pleomorphic adenoma, salivary duct carcinoma type, or myoepithelial types, or epimyoepithelial, or other types. In a prior version, cyaloblastoma was indeterminate. We decided that there are enough evidence now to think that cyaloblastoma is indeed malignant, so that was classified as malignant. So these are in just summary what happened in WHO. So now how we assess in here as cancer center or anywhere else, how we assess salivary mass. FNA is obviously the acceptable, routine, and easy, less costly way to do this. We don't encourage core biopsy. There is no need for it, and it would not be advantageous, and it may contaminate the field. Frozen section, we also discourage frozen section unless the surgeon will do completely different operation on site. So we prefer that we will have the tumor after excision in toto without. So FNA is the one we do rarely some frozen or intraoperative consultation if the surgeon thinks that the nerve or he will do neck dissection. Okay, so what's the indication to the FNA? And that is my view, and I do that all the time to the surgeon in training. If the mass is salivary primary and all these conditions are excluded, surgery has to be done, whether benign or malignant. So the indication for FNA is an exclusionary in nature. You wanted to first exclude metastasis, melanoma, squamous carcinoma, and others. You wanted to exclude lymphoma, infectious processes, reactive, and if necessary, and the surgeon knows that locally he has difficulty, we may also try to make specific diagnosis. There are obviously several reasons and limitations for that. And you were not able, in most cases, even if it's malignant, that the cytologist would grade, say, low from high grade tumor, particularly adenoid cystic, basal cell tumor, and others. You cannot differentiate between basal cell adenoma and basal cell adenocarcinoma unless you have the resection in place. You cannot diagnose carcinoma XPA unless your needle will get into the carcinoma component exclusive of the myoepithelial component. And then the differentiation between myoepithelial tumor rich PA or myoepithelial carcinoma cannot be done on cytology. Oncocytic lesions, and I will focus on that later, is impossible to differentiate between them. And cyst. And cyst is a very critical issue. I have been involved in two legal situations where the cytologist called it mucoeb, and the surgery cannot verify the mucoeb. It was cystic. There are two cases of these that the cyst collapsed, it was fibrosed, and we cannot find the mucoepidermoid carcinoma, and the cytologist called it mucoeb. So that is a dispute that sometimes can happen. The management. So as I said, for primary salivary gland mass regarding or regardless of the benignity or malignancy. It's a surgical disease and need to be taken out unless there is compromising or comorbidity that prevent that. And the current surgery for all resectable, benign and malignant, still surgery, and sometimes use XRT if necessary, particularly in adenoid cystic and other tumor. What is a problem is locally advanced, non-resectable, salivary mass, recurrent, and metastatic. These patients have very limited options, and most of the research or advancement trying to identify target for these tumors. So in the next few minutes, I will focus on the most common salivary cancer, which probably in combination would be 75 to 70 to 75% of all tumors. The rest are really maybe 65 to 70, but those are the most common that we see day to day in here. And I will focus on these for the next few minutes. So histologically, all the pathologists recognize that you can, with reasonable certainty, diagnose mucodermoid from arsenic from salivary duct and muco and adenoid cystic. Genomically, also, they are distinct, so they can group together differently. And you could see here the MAC and the SDC, they are adenocarcinoma and also ductal in origin. They are distinctly different from the adenoid cystic carcinoma, which is epithelial, myoepithelial in nature. So we'll go to the adenoid cystic carcinoma. As we said, the most likely location of their origin is the terminal duct, and where a progenitor that can have bipotent differentiation into myoepithelial and the epithelial can be duplicated in a tumorigenic way. This is one of the very few situations where dual neoplastic cells lead to a tumor. They can be ductal, very oriented, very perhaps polarized. And that polarization between the ductal and the stroma is very critical and most likely related to the role of myoepithelial cells. So in here, the tubular, cribriform, and the solid, you can see that there are dual cell population in there. This can be clearly seen by using one of the myoepithelial markers where you could see the myoepithelial in both tubular and cribriform. And in most adenoid cystic carcinoma, you're going to see a combination of these two forms, well-oriented. And then upon the loss of the myoepithelial cell, you could see that the solid adenoid cystic carcinoma are largely devoid of any myoepithelial cells. You could see here a normal duct, and the normal duct still retain the myoepithelial cells. That suggests that the myoepithelial cells are mitigating the tumorigenic effect, restraining these tumors. So within the tubular and the cribriform, which are organized, well polarized the structures, behave less aggressively than the solid, which lacks the myoepithelial cell. There is a lot of research in breast, and this is now a very viable option that maybe when cellular differentiation and biomarker combination, we can address the biology of these different form. This also, as I said, will reflect on some of the markers. So the c-KIT will only stain the ductal and not the myoepithelial in general. EGFR, on the other hand, are mostly in the myoepithelial cells. And then when it's solid, you could see all of them are positive. So tubular and cribriform, the c-KIT is positive. So the differential cellular composition and the reflection of that on the biomarkers are critical to future assessment of adenoid cystic carcinoma. As most of you know, and I'm not going to take that much time for you, they have two specific translocation. One involving the T6 and 9 and bring the 5' of the NFIP above, in front of the MEB gene and activated. And then we also and others found there is a partner, MEB-L1 and NFIP, the same NFIP on chromosome 9 and in MEB-L1 on chromosome 8. Very small percentage, maybe 10 to 15% of adenoid cystic carcinoma have that fusion. Both of them are reciprocally involved. So if the MEB-L1 is high, MEB is low. And if MEB is high, MEB-L1 is low. So there is a kind of a coordination and substitution between MEB and MEB-L1. The problem with MEB as a target is transcriptional factor. You cannot target transcriptional factor inside the cells because they varied from one tumor to the other and from one cell to the other. It's also, if you target MEB or MEB-L1, they can be on any and every cell. So there's going to be a lot of morbidity to suppress the MEB. So the efforts now is to look at downstream target of MEB and MEB-L1 that can be used for tumor only. We and others have used MEB antibody. The antibody that's available now for MEB is for the main MEB and not for MEB-L1. And it doesn't really help you that much if you could find MEB or MEB-L1. What is important is that they can be restricted to the myoepithelial or they can be in both ductal and myoepithelial cells. And we really don't know what the biological differences between tumor that have MEB only in the myoepithelial cells and the one in both. What we were looking at is trying to get another target. So our group had a deep sequencing group, adenoid cystic carcinoma, and at the same time, there were multiple groups led by Memorial that did sequencing with the same platform on adenoid cystic carcinoma. When we compared these genomic studies, we found that some of the genes that we identified and they identified were similar, suggesting that both independently with two different tumor groups have similar operation in one pathway. And that pathway was in Notch, gene 1. And then most of them were in Notch1 gene. Notch is a family and they have extracellular receptor and intracellular domains, and usually scattered, the mutation scattered throughout the gene. But in certain tumor, particularly T-cell leukemia, they are only focused on the rest part of the intracellular domain, and there is a drug that can be used in these patients. So we targeted the notch. Since the notch is the gene that we know that's the target, we saw that we may really investigate what the status of notch and notch pathway in adenoid cystic carcinoma. Notch is not really your typical receptor. It's a cell-to-cell receptor. It's not stimulated or activated by ligand. It's activated by cell-to-cell interaction. So once cell-to-cell interaction activate the notch, there is a cascade of event that will happen, and that would lead to activation of the gamma secretase enzyme that will cut the intracellular domain, dislocate the intracellular domain to the nucleus, and lead to activation of the notch and tumorigenesis. There are several different ways to block the notch: by blocking the ligand, by blocking the gamma secretase, and that's what we focused on, or by inhibiting some of these molecules. And here is the strategy. The strategy that's used in T-cell leukemia is a gamma secretase inhibitor, and that would be useful if the mutation in adenoid cystic carcinoma is similar to T-cell. So we studied notch in adenoid cystic carcinoma, and we found that probably around 10% in a notch1 mutation, and then there are also alteration in other members of the notch pathway. What is critical here is that almost all the mutation were the intracellular domain and in the rest. And then subsequently, 2 other studies of adenoid cystic carcinoma also found the same cluster of mutation in the intracellular domain, particularly the best. So we developed specific antibody to the mutated gene, and we can now screen patients for the positive. If it's positive, then the notch1 is activated and we can give the drug. If it's negative, we don't give it. So about maybe for 15% of patients have these tumor. We use it on before trial. We used it on a PDX model, and you could see that the model that have the notch kind of responded better than the one that don't. We started the trial by screening the notch by immunohistochemistry and then giving the drug, and this is one of the patients that was treated with this tumor. The next tumor that I would focus on would be the salivary duct carcinoma, and that is identical or similar to mammary carcinoma. Most of you can attest to that. And morphologically, they have comedo and everything. What we were interested in salivary duct carcinoma, whether de novo or carcinoma X pleomorphic adenoma, is the androgen receptor. We found that that 70, maybe 75 to 80 males and females have androgen receptor activation. What is important is that salivary gland are not reproductive organs. So why they are expressing androgen receptor, and particularly salivary duct exclusive of all other carcinomas. So we thought that this may be related to the activation of the androgen and salivary duct carcinoma, and that the, difference between reproductive organs and salivary gland is the relationship with the ligand, which is the testosterone. So we did immunohistochemistry, and you could see here male and female salivary gland, ducts, and the acini lack any staining, in contrast to prostate and breast, where you could see these ductal staining. In tumors, you could see both nuclear and nuclear and cytoplasmic. And remember that the androgen receptor is a cytoplasmic. So in order for the androgen receptor to be activated, it has to bind to the ligand to translocate into the nucleus and induce activation in prostate and in breast. Here we can see nuclear activation and nuclear and cytoplasmic without supposedly testosterone, particularly in females. So we did studies on salivary duct carcinoma, and we identified for the first time activation of the androgen receptor, and also identified rare variants that only occur in resistant prostate carcinoma. So primary prostate carcinoma don't have any of these variants. Only after resistant to castration and androgen therapy, they develop these alterations and these variants. In salivary gland adenocarcinoma, these are present without prior treatment in a naive patient. So it's acting as resistant prostate carcinoma. And here are the androgen itself, and these are the variants in it. So we have a cell line, then the cell line have an activated AR, so it's try to develop a tumor, and we developed tumor in animals and castrated the animals and used anti-testosterone, and it did not work. So we think that for salivary duct carcinoma, androgen receptor activation is constitutional. It does not require ligand and testosterone, and it's entirely different than breast and prostate. And we think that we should focus on the receptor itself, and this is where the research is going. Quickly, the other, and most of you also aware of this, that HER2 is highly expressed in salivary duct carcinoma as in breast, probably the same, 20, 25%, 30%. And we think that in salivary duct carcinoma, the relationship between HER2 and the PI3 kinase are critical, and therefore investigating that pathway may allow us to have some probably therapeutic targets that would be helpful to these patients. So we did PI3K mutation, and you could see here there are some of them are there. And then we have surprisingly found, if I go maybe, one of the factors that control the activation of PI3 kinase, whether in the presence of HER2 or other targets, is the P10 gene. And the P10 is like a lipase kind of an enzyme that block and control the PI3 kinase activation. Just remember that that's naturally blocking the activation of PI3 kinase. In this case, we found that most of the salivary duct carcinoma will have P10 loss. So whether the activation of the PI3 kinase as normal or others, the lack of P10 as a protector allow the HER2 activation, and it may be a marker to select some patients. here is an immunohistochemistry panel of 3 tumors, and you could see here the stroma is positive, tumor is negative, same here, starkly negative. And then HER2 is positive here, weak and negative there, and the phospho-AKT, which is a downstream one, is also activated in some and not others. So we think that the differential expression of these markers may segregate subtypes of these patients that can be targeted for therapy. So we think that probably HER2 can be used in some patients based on that profile, EGFR and PI3 kinase, if the alteration and the mutation in that gene. A few seconds on mucoepidermoid carcinoma. It's a very common tumor, particularly in children, and it's also similar to salivary duct carcinoma, arise from the main duct. These are one of the only tumor in whole salivary gland repertoire that would be graded, and we can grade them into a grade 1 or low, intermediate, and high, poorly differentiated by the presence of these mucin foci in there. They also characterized by specific translocation in probably 75% of the cases. The use of the fusion for predicting biology and also excluding tumor may be dangerous. We did not find any difference between tumor that have fusion and no fusion as far as the biology. They can be present in high grade as well as low grade. And then we have mucoepidermoid that don't have these fusion. So the diagnosis, if it's positive and you think it is mucoepidermoid of high grade, it's okay. But if it's negative, you can rely on histology again, and I will get to that in a minute. There is no specific target. Again, the fusion transcript is very difficult to analyze. We don't have transgenic mice for that model. We tried and we were not successful at all. So some of the high grade and recurrent, they are treated empirically by EGFR and HER2, but nothing specific to this. The last few minutes will just highlight very few topics, and then we can address some of the issues that were raised in the previous lecture. One of the common mistakes and sometimes confusing issue, the oncocytic is what's called nodular oncocytic hyperplasia, where you could see the entire gland and sometimes bilateral studied with these small nodules of oncocytosis. This could cause differential diagnostic problem, and particularly for cytology, they can aspirate these satellite nodules, and then they will call it metastatic carcinoma. Indeed, hyperplastic and usually unilateral, but can be bilateral. This is obviously different from either oncocytoma or oncocytic carcinoma, and that can be clarified. One gland, one mass, and very clear. So that is sometimes in consultation becomes an issue. Close to both the oncocytic hyperplasia, adenoma, and carcinoma is the warfarin. And sometimes FNA in solid warfarins or in a regular warfarin could lead to diagnostic difficulties, most commonly with mucoepidermoid carcinoma. And sometimes mucoepidermoid carcinoma can develop rarely in that setting. So that kind of keep in mind in the differential diagnosis. The other, which was alluded to somehow in the previous lecture, is myoepithelial and pleomorphic adenoma and the difference between them and the overlapping nature of them grossly and also microscopically. Um, Myoepithelial or pleomorphic adenoma also derive from the terminal duct where epithelial and myoepithelial cells are a part of it. So pleomorphic adenoma, adenoid cystic, epimyoepithelial, and myoepithelial are derived from the same thing. So you may see that spectrum of changes within one tumor and different part of the tumor with a dominance of myoepithelial in one part, dominance of ductal, dominance of stroma, and then variation of squamous differentiation to fat, cartilage, and so on and so forth. Similarly, here you could see very loose stroma and myoepithelial cells, and some of them are solid tumor. And the difference would be the invasiveness of the lesion. These are also myoepithelial. They can be kind of striated and making shapes and forms. The other one that I also would like to highlight a little bit is the basal cell tumor. Similar to adenoid cystic, they arise from the terminal, and instead of the myoepithelial, it would be a basal cell in nature. How that can switch the peripheral ductal cells into a basal, like in prostate, versus myoepithelial, it's an enigma, but they arise from the same and they have a basal and myoepithelial, and you could see the dual cell population here. The difference between benign and tumor malignant is the invasiveness. So you cannot make definitive diagnosis on cytology, and also you need to do surgery in order to determine the invasive nature of it. That is one that I want to highlight. The other, again, is the acinic and secretory. They were one and the same. We used to call them variant before they were separated and were identified. Then the story is very interesting because the pathologist that identified secretory carcinoma was studying acinic cell carcinoma in breast. And when he was reviewing the acinic cell carcinoma in breast, they found them that they overlap with the secretory carcinoma of breast. So he published this, and then the head and neck people studied this one. So morphologically, they can be identical. And both of them, if there is no high-grade transformation, there is no difference biologically. The only difference is when secretory carcinoma become high-grade and invasive, they may be eligible for NTRK therapy, and that is a possibility. But for surgically resectable secretory and equally acinic cell carcinoma, the treatment is the same. High-grade transformation, most of you know, that happen in salivary and adenoid cystic carcinoma, and can happen in ductal carcinoma, where you could identify acinic and poor differentiation, ductal and poor differentiation, and the like. If the transformation is epithelial, then we call it high-grade transformation. If it's mixed epithelial and mesenchymal, we call it carcinosarcoma. The role of IHC and genetic alteration that can be in a discussion, and Dr. Slutwig can address that. We don't use that much of an IHC, and we look at the morphology as a whole, the dominant morphology as a whole. I think Peter said very interesting observation that they can be present in any kind of tumor, foci, cribriform or ductal or myoepithelial and alike. So variation is common in salivary gland tumor. The main issue for pathologists is the dominant and the most impressive or common component of it. If it's an adenoid cystic carcinoma, it is adenoid cystic carcinoma. Now, if you make a mistake and call epimyoepithelial carcinoma and adenoid cystic carcinoma, it's common and it's not going to change the management. Both of them would be resected the same. Maybe if it required, it would be more adenoid cystic carcinoma, but for primary surgery, I don't really sweat over epimyoepithelial or adenoid cystic carcinoma, as long as it's resectable and as long as the surgeon is available. So the use of immunohistochemistry and genetic alteration need to be controlled by the pathologist, by his belief of the histopathologic variation, and if the genetic alteration is positive, it's good, but if it's negative, your histology should be the main focus. Now, very few perspective to end up with. We think that major salivary gland carcinoma are distinct entity, and they cannot be grouped together and treated as high-grade cancer. Each tumor should be treated separately based on their cellular and behavioral and biomarker context. And then that in the future, it's not yet up now, that we probably have to be prepared for an integrative biomorphology reporting, where we can incorporate all of the immunohistochemistry genetic into the reporting. We're not there yet. And then the use of non-invasive fine needle aspiration, along with the molecular marker specific for all of these tumors, to make a prediction and perhaps specific diagnosis if the patient is unresectable and he can benefit from some therapy. And I thank you and stop here. And I hope I didn't take that much time.
Yeah, thank you so much, Adel, for this very interesting presentation that covers quite a lot of aspects of salivary gland tumors, both very practical and also very sophisticated. We have still time for a few questions, and there are already a little bit on the chat box. And one of the first, you started with some embryology. And my first question relates to that embryology, whether the salivary glands are coming from ectoderm or from endoderm. Maybe you can see it. So we have also been told in the past that it's both, that the parotid gland is from the ectoderm and the submandibular and sublingual are for the endoderm. And I think that it doesn't matter so much, at least not for histology and tumor development. Do you agree?
Yes, I do agree completely.
Okay, then the next question is a little bit more complicated. The other question is on the progenitor cell of the adenoid cystic carcinoma. That's an issue you have already addressed in your lecture, so we can skip that. but the next question is a little bit more complicated about the molecular pathology. And the question reads that P10 has to be downregulated for an increased HER2 action. And now the conclusion is that when you see positivity for P10, that means increased expression of this protein, while it should be decreased for tumorigenesis. But I think that the increased expression of P10 implies that the protein doesn't function properly, and therefore its positivity is increased. And that goes on with its significance for the tumorigenesis. You agree?
The P10 is a very complex molecule. It's universal, so you could see it in endothelium, smooth muscles, stroma, everything. So it should be completely intact because it's a critical component of the PI3 kinase and others. So the loss of the P10 is the critical part because it has to be maintained in tumor and in stroma. So if you look at salivary gland, you'll find it in the duct, the acini, and everywhere. So we think that the loss of P10 is a factor in inducing more activation of the PI3 kinase because there is no inhibition to the PI3 kinase, even in a constitutional way. Together with activation of HER2, kind of induce more tumorigenesis and aggressiveness that may be important. So the issue of how P10 is high or low is not, I can't answer that. I answer yes, it's present, or no, it's not present.
Yes, I think so. Then the last question, because we have a lot of time, we have not so much time left, whether there is any correlation between salivary duct carcinoma and HER2 positive breast cancer. Maybe in the question relates whether it occurs together in the same patient.
That is a very relevant question, and we always struggle with that, particularly in female. So salivary duct carcinoma with high HER2 in female, we always ask the clinicians to see if the patient had breast, and but we see it independently from the breast, and it's a very, very complex issue because they're the same percentage. High expression of HER2 is about 20 to 25%, and similar to the breast. And then androgen also is positive in the breast. So the hormonal and the HER2 issue between salivary gland, duct carcinoma, and mammary carcinoma is really intermixed, and it depends entirely on the clinical presentation of the patient.
Then the final question is a question that pops up twice. That's a question, that is a very practical question. Does CD117 help in differentiating between adenoid cystic carcinoma and epithelial myoepithelial carcinoma?
Yes. I don't want it to be like just a nitpicking on this one. We think that it's like a splitting hair sometimes.
Okay.
Yep. Splitting hair. And in that case, I would say if the myoepithelial cells are the dominant and very prominent in nature, then I would call it epimyoepithelium. If the myoepithelium is pushed by the duct and it's very, very flat, I would go for adenoid cystic carcinoma. But remember, epimyoepithelial does not really form cribriform pattern. They are usually ductal myoepithelial. So if you look at the entire tumor and see cribriform along with duct, it would not be an issue. If you're looking at a smaller biopsy or segmental resection, that may be a problem. But if both of them are carcinoma, both of them should be resected.
Sure. Well, I think now we have to finish this very interesting session on salivary gland, and it's my pleasure again to express my gratitude to the both speakers, Dr. Mahdavi and Prof. Al Nagar, for their very worthwhile contributions, and I hope that the audience has enjoyed the whole session as much as I have done. And now I give the floor back to the organizer of the meeting, Dr. Pouyan Aminishakib. Pouyan, maybe you would like to make some closure notes.
Thank you very much, Professor Slutbeck, and hello, Professor Al-Najjar. Thank you very much for accepting our invitation to this panel. It was great, impressive lecture, and also I would like to express my appreciation to Dr. Mahdavi for such a great presentation. And at this part of the session, I would like to give virtually certificate of presentation. The first one is for Professor Dr. Peter Slutbeck. Pete, you kindly supported us during recent months, not only in oral maxillofacial pathology congress, but also in this panel. Thank you very much for your kind support. And the next one.
My pleasure.
Thank you. And the next one, Professor Dr. Al-Najjar, thank you very much for your kind and impressive contribution to this panel. It's a great honor for us to have you in this course. Thank you very much.
Thank you.
And the next one, Dr. Mahdavi, thank you very much for your especially case presentation in the first and second lectures. And at the end of this panel, I would like to express my appreciation to all of our audience and hope to meet you next week. And I would like to ask all of you to turn on your cam to have a group photo at the end of this panel.
That's great.
Would you please open your, turn on your cam to have a group photo as a memory of this great panel today. Thank you. Thank you. Nice to meet all of you.
Bye-bye.
Thank you very much and have a nice day. And hope to see you next week. Have a nice day. Bye-bye.
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 Bye.